Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome, everybody. It's actually my pleasure to welcome you all on behalf of Saudi Society for Blood Disorders in our forum, MENA Forum for Challenges in Hematology 2020. We have started this forum since September 2020, and our plan to continue until March 2021. We usually have this webinar on the last Monday of each month. On this forum, we try to cover challenging topics or diseases in hematology. So far, we have discussed, we have webinar on Langerhans cell histocytosis. We had webinar on Waldenstrom macroglobulinemia. We also had webinar on amyloidosis management. I would like first to take a chance to thank our sponsor for this forum, our platinum sponsor Janssen, and our gold sponsor Hikma. So for today's webinar, we will discuss the challenges and updates on multiple myeloma. We are really lucky today to have our distinguished speaker, Dr. Philip Moro, and Dr. Maria Matios, and Dr. Saud Al-Haili. Our agenda for today, we will have almost 60 minutes of presentations. Each of our guest speaker will have around 20 minutes time for presentations, and then we'll have around 30 minutes for question and answer and discussions. Prof. Moro will discuss the update and frontline management in multiple myeloma. And Dr. Matios will present about novel therapeutic modality for advanced or relapsed multiple myeloma. We'll have then time to discuss challenge cases with Dr. Saud Al-Haili. Before we start, I would like to bring to your attention, as most of you may know, that we record all these webinars, and you can access this webinar through our account on YouTube and other social media. So without any delay, we'll start our first presentation with our first speaker, Professor Philip Moro. Most of you know Professor Moro very well. So he's the head of the hematology department at the University Hospital of Nantes in France. He was the head of the France myeloma group, the IFM, between 2006 and 2009. Professor Moro have a lot of publication. He had more than 280 peer-reviewed publication on the journal. Without any further delay, I would like to welcome Professor Moro, and the time for you. Thank you for joining us.
Thank you very much, and good evening. Thank you for this invitation. And I would like to share with you some data on the frontline treatment for patients with newly diagnosed myeloma. We are going first to speak about the patients that are not eligible for high-dose therapy and autologous stem cell transplantation. As you know, we are proposing different treatment options for patients that are not eligible for autologous stem cell transplantation based on phase 3 trials. And one very important study was published quite a long time ago now, the VISTA study that did establish VMP as one of the standard of care on 344 patients with a median time to progression of 2 years in the VMP arm of the study and a median overall survival of 56 months. You know that Subsequently, the first study compared prospectively Len-Dex versus MPT and lenalidomide and Dex continuously on more than 500 patients was associated with a good progression-free survival, 26 months in median, and median OS of 5 years. So Len-Dex is also considered as one of the standard of care. You know that in 2017, Dr. Brian Dury reported the result of the SWOG study that did compare prospectively lenalidomide and Dex until progression, Len-Dex, versus VRD with the addition of bortezomib during 8 induction cycles, and then subsequently patients were treated with Len-Dex until progression. So VRD followed by Len-Dex versus Len-Dex. And the study did enroll not only elderly patients, but also young patients. But if we are focusing on elderly patients above the age of 65 years, you see the median PFS of 34 months with VRD followed by Len-Dex, and the median overall survival was 65 months. Recently, the study was updated with a very long follow-up, and you can see that VRD is remaining superior as compared with Len-Dex for overall survival for elderly patients, but there is only a trend for a better overall survival that is not statistically significant. So in many countries, we are supporting VRD as one possible option for elderly patients as well. But one very important step was the addition of daratumumab on top of standard of care, and Dr. Mateos reported in the New England Journal of Medicine in 2017 the results of the Alcione study that did compare prospectively VMP versus VMP plus daratumumab. This is the study design, 9 cycles of VMP, the same schedule of the VISTA study with bortezomib subQ, versus Dara VMP, 9 cycles, followed by Dara maintenance with a primary endpoint of progression-free survival. More than 700 patients were randomized, and you see the update analysis of progression-free survival. Definitely, the addition of Dara is improving significantly progression-free survival. The median PFS with VMP 19 months, and the median PFS with DVMP 36 months, so hazard ratio of 0.4. So a huge improvement that translated into a better overall survival. You see here the hazard ratio of 0.6 in favor of Dara VMP versus VMP alone. So 40% reduction in the risk of death. And definitely this is the first study showing that with the quadruplet upfront, including daratumumab, there is an overall survival benefit at the end of the day. So I put here the benefit of Dara VMP versus VMP into the Alcione study. But to my opinion, the best results ever reported are those of the Maya study that did compare Len-Dex versus Len-Dex plus daratumumab until progression, PFS as a primary endpoint. More than 700 patients were randomized, and you see that more than 40% of the patients into the study were older than 75 years of age. And definitely when the paper was published in the New England Journal of Medicine in 2019, you see that the control arm, Len-Dex, is performing very well with a median PFS of almost 32 months. So that's a very good control arm. But if you are adding daratumumab on top of Len-Dex, the hazard ratio is less than 0.6, in fact, showing outstanding results with DRD. This is true for almost all subgroups of patients. Maybe you can see here that patients with a higher risk cytogenetics are not benefiting that much of daratumumab, and this high-risk subgroup of patients is remaining a very difficult to treat one. There is only a trend for a better PFS with DRD versus Len-Dex. So no overall survival data that are immature with a short follow-up at the time of the presentation, but we are going to hear at the next ASH next week outstanding results with a longer follow-up for PFS. We can anticipate to have a median PFS of 55 months with DRD, and that's definitely outstanding since it is the PFS that is currently achieved with stem cell transplantation up front. So DRD is definitely a very, very good regimen. And if we are focusing on elderly patients, very elderly patients above the age of 75 years, the PFS benefit is also observed for patients above the age of 75 years. As you can see on this slide, the hazard ratio is remaining very, very good in favor of DRD. So this is a summary of the ongoing phase 3 studies or recently published, looking at VMP as a backbone in blue on the left-hand side of the slide, and you see that VMP DARA is the best one, definitely. In red, you have the Lendex combinations recently tested in randomized studies, and on the right-hand side of the slide, you see the VRD results of DRD, the MAIA results, with the best progression-free survival ever reported. We are also awaiting for some other trials that are ongoing, Lendex as a backbone, plus or minus ixazomib, Lendex plus or minus ELO, or VRD as well, plus or minus CD38 antibodies, VRD plus or minus DARA, or VRD plus or minus isatuximab. So all these results are pending with the exception of Tourmaline, the Lendex versus Lendex ixazomib that was presented at EHA, will be presented as well at ASH next week. And you see that ixazomib is improving progression-free survival, but not significantly. There is only a trend for a better PFS with the triplet combination. But definitely, Lendex is inferior to DRD, to my opinion. So definitely, the frontline, the guidelines are going to change. This is the example of the European guidelines, the ESMO EHA guidelines, and definitely VMP DARA or Lendex DARA will become the first option in the near future on top of VRD for elderly patients. Let's discuss now the results of recent studies for patients that are eligible for autologous stem cell transplantation. The European guidelines were proposing in 2017 that the guidelines will be updated soon, a triplet induction with bortezomib dex as a backbone, plus a third agent, a single stem cell transplantation, and Len maintenance until progression up to the age of 70 years for fit patients in good clinical condition. This is based on the IFM 2009 study and the EMN02 study recently reported, indicating that frontline stem cell transplantation is the standard of care. This is the design of the EMN02 study. After an induction with VCD, CyBorD, patients were randomized to receive either VMP and no stem cell transplantation or high-dose therapy. The paper was published recently by Dr. Cavo, and you see that progression-free survival was highly improved with stem cell transplantation frontline versus VMP with a median follow-up of 5 years. The median PFS is 56 months with stem cell transplantation versus 42 without stem cell transplantation. So a 14-month benefit. The IFM study did compare VRD versus VRD and stem cell transplantation, and the same benefit for stem cell transplantation, a 14-month difference, 50 months median PFS with high-dose treatment versus 36 with VRD alone. But importantly, when we are looking at minimal residual disease negativity into that study, patients in blue reaching MRD negativity are enjoying a better overall survival as compared with patients that were not able to reach MRD negativity. So definitely MRD negativity is an important endpoint for studies looking at high-dose treatment for young patients. So what about induction? We need a fast control of the disease. If possible, we need to achieve MRD negativity with minimal toxicity so that the patients will proceed to stem cell transplantation. We did compare prospectively VTD versus VCD, and we showed that VTD was associated with a higher response rate versus VCD. So definitely the combination of a proteasome inhibitor and an IMiD is a good option, but the safety profile is different with VCD, a higher rate of neutropenia, but with VTD, a higher rate of peripheral neuropathy. But the two regimens are associated with high response rate, definitely. So why not switching from VTD to VRD and using lenalidomide instead of thalidomide? This is the paper published last year by the Spanish group showing outstanding response rate with VRD before stem cell transplantation. And 70% of the patients were able to reach VGPR or better after VRD induction, and the responses are deepening over time after induction, after stem cell transplantation, but also after consolidation. So VRD is quite well established now in Europe, but why not switching from bortezomib to carfilzomib with the KRD regimen? KRD was tested in a phase 3 study from Italy, the Forte study, looking at KRD versus carfil cyclophosphamide dex, KCD. And the rates of response before stem cell transplantation were definitely higher with KRD versus KCD, 73% VGPR or better with KRD, 4 cycles. Keep in mind that with 6 VRD, the VGPR rate is something like 66% in the Spanish experience. So KRD is a good option. But maybe we can add a monoclonal antibody on top of a triplet. That's we did into the CASSIOPEIA study. We did compare VTD both before and after stem cell transplantation versus VTD plus daratumumab. And we were able to demonstrate that DARA was associated with a higher response rate as compared with VTD alone, both before, after induction, after stem cell transplantation, and before maintenance. And when we looked at the depth of response, the quality of the response, before maintenance and after consolidation, in the DARA arm of the study, MRD negativity 10 to the minus 5 was reached in 60%, more than 60% of the patients versus 43% of the patients only with VTD alone. And this depth of response, this quality of response did translate into a better progression-free survival. And if you are looking at PFS in the DARA arm of the study, the 18-month PFS is 93%, the best results ever reported in a phase 3 study with a hazard ratio less than 0.5. So based on this study, DVTD is now approved by the European authorities and FDA as well in the setting of stem cell transplantation. There is already a trend for a better overall survival, although the data are immature because of the short median follow-up. Why not looking at DARA VRD instead of DARA VTD? And this is the basis of the phase 2 Griffin study performed in the US on almost 200 patients. A very similar design, VRD both before and after stem cell transplantation versus VRD plus daratumumab. And the primary endpoint, the stringent CR rate by the end of consolidation and before maintenance, was in favor of daratumumab with a higher response rate as well. So this combination, DARA VRD, is currently tested in a prospective fashion into the Perseus study. Why not looking at KRD plus daratumumab? And this is the MASTER study, a phase 2 study that was proposed by a cooperative group in the US, reported at ASH last year. KRD-DARA, very active combination, 4 cycles before stem cell transplantation with a systematic assessment of MRD negativity after induction, after stem cell transplantation, after 4 and after 8 cycles of consolidation with the same quadruplet combination. And when patients were twice consecutively MRD negative, the treatment was stopped. And when looking at the results, MRD negativity 10 to the minus 5 by NGS was reached in 40% of the patients after 4 induction cycles, in 73% of the patients after stem cell transplantation, and in 82% of the patients after the first 4 consolidation cycles. The treatment was stopped when patients did reach MRD negativity twice consecutively, and the data are not yet published, but Dr. Costa is reporting that no patient with MRD negative twice consecutively did relapse. So a very provocative study showing that MRD could impact on the treatment decision in the future. So what about tandem stem cell transplantation? We have the recent EMN02 study that did compare in the intensive arm of the trial single versus double stem cell transplantation on more than 400 patients. And interestingly, progression-free survival, but also more importantly, overall survival is improved with tandem stem cell transplantation, especially in the subgroup of patients with high-risk cytogenetics. And in many centers in Europe, outside clinical trials, we are proposing tandem stem cell transplantation for patients with high-risk disease. So what about maintenance that is systematically proposed? Maintenance is based on lenalidomide that is approved based on this meta-analysis on 1,200 patients comparing len versus no len or len versus placebo, showing an overall survival benefit of more than 2 years in favor of len maintenance until progression. This is the labeling of the approval of len maintenance. But we can also propose ixazomib, an oral proteasome inhibitor based on the tourmaline MM3 study reported last year in the Lancet. But as you can see, the benefit of IXA is marginal, 5 months only for progression-free survival. So IXA is safe, but not that effective as compared with len. So why not combining IXA and len? And this is the ongoing Spanish study. After stem cell transplantation and consolidation, patients are randomized to receive len or len plus ixazomib. And we are awaiting for the results of this very important study. Daratumumab is also tested in the CASSIOPEIA study. After consolidation, patients are randomized to receive no daratumumab or daratumumab during 2 years. So definitely the landscape will probably change in the future for maintenance, and potentially these are the future European guidelines. We are going to propose quadruplet induction with the addition of a CD38 antibody on top of VTD or VRD. Probably we can propose tandem for high-risk disease, and maintenance definitely will be based in the future on len plus IXA or len plus a CD38 antibody. And I thank you for your very kind attention today.
Thank you very much, Professor Moro, for this nice and detailed presentation. We have time for a couple of questions. So I have a question here from Mustafa. He's asking, what combination do you recommend for high cytogenetic risk patient more than 70 years old, so not eligible for transplant?
Oh, 70 years old. That's a very difficult question. If possible, if patients are able to tolerate VRD, I think that it could be interesting to combine a proteasome inhibitor and an IMiD. And we have the experience of the SWOG study, for example, showing that VRD can be tolerated in elderly patients without comorbidities, to my opinion. But into the SWOG study, we don't have the results of the cytogenetic assessment into the paper from Dr. Dury. So VRD is a possibility. We can also use the VRD light regimen with bortezomib once weekly with reduced dose of lenalidomide. And this is also very effective, but that's only a phase 2 study published in the British Journal of Hematology. I think that also in the MAIA study, we are going to update the results of progression-free survival. And from what I know, I think that it is not possible to overcome with DRD the poor prognosis of high-risk cytogenetics, but there is a trend, a big trend now for a better PFS with VRD. So I would answer, if possible, VRD, and VRD light is a good option for high risk.
Okay. Thank you very much, Dr. Moreau. I have a question myself. So as you mentioned on the Spanish study in 2019, but the more VRD they give, up to 6 cycles, they were able to achieve more response.
Yes.
So the question that we face on clinical, like if you give like 4 cycles and patient still did not plateau, so will you proceed for collection transplant? Will you give more cycles to achieve more response? So what's your practice on this questions?
That's a very, very good question. What is the optimal number of cycles prior to stem cell transplantation? And unfortunately, we don't have a comparison of 4 versus 6 VRD cycles. But when you are looking at the Spanish study, you see, and I showed the slide, that the response rate is still increasing when you are moving from 4 to 6 cycles of VRD. So definitely, if the patient can tolerate, and we know that 6 VRD cycles is, to my opinion, quite safe, you can increase up to 6 cycles in order to increase the response rate, but also probably the MRD negativity rate. We don't have these results for quadruplet combination, yet we don't have any comparison of 4 versus 6 VTD DARA or VRD DARA. But I think that now currently we can easily use 6 induction cycles before stem cell transplantation.
Interesting. Thank you, Professor Moreau. There is another question, maybe the last question. So he's asking here, any difference in using Zometa versus Exchiva as bone-directed therapy in your practice?
No. In fact, there are some guidelines, on bone disease in the setting of frontline stem cell transplantation. So in my routine practice, I'm using Zometa, zoledronic acid, in fact.
Okay. Thank you very much, Prof. Moreau. Thank you for this nice slide and presentation. So I would like now to move to our next presentation with our next guest speaker, Dr. Maria Motes. Dr. Matthews, she's a consultant physician and director of the myeloma program at University Hospital of Salamanca in Spain. Dr. Matthews is the coordinator of the Spanish myeloma group and member of BIFIMA board. Dr. Matthews have a lot of publications. She had more than 100 peer-reviewed papers on the international journal. We are glad to have you here with us today, Dr. Matthews, and the time for your presentation. Thank you.
Thank you very much for the introduction, and thanks also for the kind invitation to be with you today in this meeting in which I will jump from the newly diagnosed myeloma patients addressed by Philippe Moreau to the novel therapeutic modalities for advanced multiple myeloma. And in order to avoid an important gap between the first line and the late advanced stage of the disease, I decided to put just some slides as a bridge therapy. I would say that as a bridge between the first line and the late advanced stage of the disease. In this slide, you can see my conflict of interest, and definitely at the relapse situation, I think that in order to deliver the most effective regime, the safest one, and trying to maintain definitely these guidelines are a bit older, and new guidelines are coming, basically because, as I previously said, the first line of therapy is changing, and as soon as the first line of therapy changes, the possibilities for utilizing rescue therapies are going also to change. And in fact, this is a summary of what Philippe has just showed you, and how in the first line of therapy, patients will receive a VRD or DARA VTD, VTD CyBorD followed by transplant and then maintenance, and in the patient is non-eligible for transplant, DARA VMP, VRD or DARA RD. This puts in context that most patients will receive lenalidomide as part of the first line of therapy and progress while on lenalidomide. With either carfilzomib or pomalidomide and dexamethasone. Another possibility, especially if the patient is no anti-CD38 naive, to select maybe pomalidomide, bortezomib and dexamethasone, bortezomib and dexamethasone plus selinexor. The combinations in red means that these combinations are being evaluated in phase 3 clinical trials. This slide represents the superiority of daratumumab or isimab plus carfilzomib and dexamethasone as a potential new standard of care, and the same for pomalidomide, bortezomib and dexamethasone, or even the new drug selinexor in combination with bortezomib and dexamethasone, but also daratumumab in combination with pomalidomide and dexamethasone, and this combination will be presented at the end of this week at ASH meeting, and I decided to put here venetoclax in combination with bortezomib and dexamethasone as a combination that we have maybe to restrict to patients with 11-14 translocation. This slide represents again what we can consider the new guidelines for the management of patients with multiple myeloma, just to emphasize the fact that most patients between the first and the second line of therapy will be exposed to proteasome inhibitors, immunomodulatory drugs, anti-CD38 monoclonal antibodies, and maybe the patients will be almost all of them refractory at least to the last line of therapy. So if we go to the third line and beyond, it's true that we can potentially select some POMDEX-based combination, especially if the patient did not receive a pomalidomide in earlier lines of therapy, but the future definitely is to utilize novel agents, selinexor, dexamethasone, melflufen, but specifically, and I will focus much more during my presentation on the BCMA targeted therapy, and specifically in the cell therapy and in the CAR T cells. You know that the cell therapy in myeloma today is basically targeting BCMA. BCMA is extensively studied in multiple myeloma, and you know that it's a protein quite specific from the plasma cells, and it is overexpressed in malignant plasma cells. You have to know that BCMA has physiological functions on the normal plasma cells, supporting the survival of the long-lived plasma cells, and it is involved in the production of immunoglobulins, overexposed myeloma cells, microenvironment, and conventional drugs. We know that BCMA is also expressed in the serum, and increased serum BCMA levels are associated with disease progression and poor outcome. You know that we can target BCMA through CAR T cell therapy, T-cell engager antibodies, or antibody drug conjugated. And as I previously said, I will focus basically on the CAR T cell therapy, that is something completely new for the management of patients with multiple myeloma. This is one of the first CAR Ts targeting BCMA evaluated in multiple myeloma, BB2121 or ide-cel, and you can see here in the graph how these CAR Ts are basically including autologous T cells transduced with a lentiviral vector encoding a chimeric antigen receptor against human BCMA. The targeting domain is BCMA and the co-stimulatory domain is 4-1BB. BB2121 was evaluated in a small series of heavily pretreated myeloma patients in a phase 1 clinical study published 1 year ago in New England Journal of Medicine. And different doses were evaluated. The first concept is that the efficacy was dose dependent, but overall 85% of patients achieved at least partial response with a median progression-free survival of approximately 1 year. We will evaluate later on the toxicity profile for CAR-Ts, but updated data will be presented at ASH meeting. Overall response rate around 80%. Approximately 40% of the patients achieved complete response. Median duration of response 10.3 months, 9 months of median PFS. But for me, what is much more surprising is the median overall survival of 34 months, indicating clearly like CAR T cells are going to cover an important unmet medical need. But definitely following this phase 1 clinical trial, we have here the KarMMa study. This is a phase 2 pivotal study conducted again with ide-cel, BB2121 in 128 relapsed and unrefractory myeloma patients. Here you can see the baseline characteristics of the patients, and basically the median number of prior lines of therapy was 6. Some patients had high-risk cytogenetic abnormalities, high tumor burden, and even extramedullary disease. But I think that the common denominator in order to compare all these therapies, although you know that cross-trial comparisons is not appropriate, is the population triple refractory to proteasome inhibitors, IMiDs, and anti-CD38 monoclonal antibodies. And 84% of the patients were 3-drug class refractory. Again, in this study, different doses were evaluated, and again, the efficacy is dose dependent. And if we focus on the intent to treat patient population, 73% of overall response rate with a 33% of complete response or stringent complete response. Median time to response is quite rapid, and in 1 month we see how the patients are responding, and the median time to complete response is of approximately 3 months. The median follow-up of this study at the moment of presentation at ASCO and at EHA was of approximately 13 months. The overall response rate, over 70%, was sustained across the different subgroup of patients, as you can see here, and the exception would be patients with RISS3, for which you can see here how the overall response rate was lower than 50%, and we don't know exactly what is the rationale, because you can see here how the overall response rate is quite sustained for patients with high-risk cytogenetic abnormalities, including those patients triple drug class refractory, for which the overall response rate is consistent with the overall response rate reported in the intent to treat patient population. This is the progression-free survival, and overall the median PFS was of approximately 9 months, and again patients receiving the highest dose, 450 millions, the median PFS was of approximately 1 year, and the best the response, the longest the progression-free survival, and patients achieving at least complete response. Remember, approximately 30%, the median progression-free survival was 20 months. Median overall survival is immature yet, and at the moment of presentation, the median overall survival was 19 months, but you can see how most events are censored, and most patients are censored at the time of last follow-up, and maybe we need a longer follow-up in order to know the real benefit in terms of overall survival. From the safety point of view, well, you have to keep in mind, I would say, 3 key toxicities when we manage CAR T cells in patients with multiple myeloma. And this toxicity profile, I would say that is more or less common to all CAR T cells, at least targeting BCMA. Cytokine release syndrome occurring in approximately 84% of the patients, but it's true that in most patients, the cytokine release syndrome was grade 1 and 2, and in fact, in only 5% of the patients, the CRS was grade 3 or grade 4. With the BB2121, we know that the median time to onset CRS is 1 day, and the median duration is of approximately 5 days. The second important adverse event is quite manageable with tocilizumab targeting the receptor of IL-6, and if with tocilizumab is not enough, it is necessary sometimes to continue with dexamethasone or even anti-IL-1 monoclonal antibodies. The second important adverse event is neurotoxicity, usually following cytokine release syndrome, but much less frequent, only present in 18% of the patients, and in most patients grade 1 and 2, and also manageable, usually with corticosteroids. And the third important adverse events are cytopenias. Very common, no dose related, but present in almost all patients, neutropenia and thrombocytopenia. And it's true that the median time to prolonged recovery is approximately 2 months, and in real life, in my experience, usually it takes approximately months after the CAR-T administration to have a completely the neutrophils counts as well as the platelet count. B2121 is the cell, as you know, maybe you will be the authorities, the important filter cell that you can see here in this slide. The answer is no, and in the right part of the slide, you can see how the co-stimulatory domain is the same for 1BB, but when we go to the chimeric antigen receptor targeting BCMA, this CAR-T has 2 binding domains, and these 2 binding domains will allow to this CAR-T to have more ability for the BCMA expressed on the surface of the plasma cells. And this CAR-T filter cell used the identical construct used in the LEGEND-2 study, presented by China some years ago at ASH meeting in a series of almost 60 relapsed and refractory myeloma patients with a good outcome, because the median PFS was 20 months and the median overall survival of approximately 3 years. But today we have a more solid data coming from the CAR-T2-1 phase 1b/2 study conducted in relapsed and refractory myeloma patients that had received at least 3 prior lines of therapy or double refractory to PI and IMiD, and patients basically were all of them exposed to proteasome inhibitor, immunomodulatory drug, and anti-CD38 monoclonal antibodies. Well, the study design is common to all CAR-Ts: screening, apheresis, bridging therapy if needed, lymphodepletion with cyclophosphamide plus fludarabine, followed by CAR-T infusion and post-infusion assessment. These are the baseline characteristics of the 97 patients that have been so far recruited, and this will be presented at ASH meeting. And I have extracted the information from the abstract, so I will invite you to see the oral presentation, because maybe you will have the opportunity to see more data. But basically, well, median age 60, median number of prior lines of therapy, again 5, and let's go to evaluate what I previously said as common denominator. Almost 88% of the patients were triple refractory, and almost all patients were refractory to the last line of therapy, and 41% of the patients were even penta-refractory. So population similar to that recruited in BB2121, heavily pretreated myeloma patients. And the efficacy is excellent, because while the median follow-up is of approximately 9 months, but you can see how the overall response rate is 95%, but stringent complete response or complete response was achieved by almost 56% of the patients. The median progression-free survival has not been reached yet, but it's important to see how 6 months PFS was 87.4% and 6 months overall survival 94%. So although we need definitely longer follow-up and more mature data, this cilta-cel seems to be, at least although trial comparisons are not appropriate, better than BB2121, at least in similar populations. Minimal residual disease was evaluated in this study, and 94% of the patients in which the minimal residual disease was evaluated was negative. Again, the median time to first response was 1 month, and this is something that we see in the clinic because just in the evaluation after the first month, in the first month after infusion of CAR-T, you can see how the free light chain, kappa, and lambda are usually undetectable. The bone marrow is empty, there is not any plasma cells, and the M component is decreasing slowly, but at the end, the median time to complete response is of approximately 8 months. Here you can see the swimming plot of the duration of the response for these 92 patients that will be presented at us, and definitely patients with a longer follow-up. In the bottom of the slide, most of them are in green, and green, if we go to the legend as stringent complete responses deepen over time, and well, we need a longer follow-up in order to see more mature data in terms of outcome, but it seems it looks like something great. From the toxicity point of view, something I previously said you for BB2121, cytokine release syndrome, 94.8% of the patients, but only 4% grade 3 and 4. Important consideration, the median time to onset is here 7 days instead of 1 for BB2121, but the duration is of approximately 4 days. Most patients grade 1 and 2, 10% grade 3, 4, and manageable with usually corticosteroids and in some cases with anakinra. And again, hematological toxicity, as I previously said, and again, in approximately a median of 2 months, the hematological toxicity recovered. The maximum expansion of CAR-T is observed at day 14, and this is in line with other CAR-T cells. And when we evaluate in more detail the cytokine release syndrome, you can see here how, as I previously said, most patients developed grade 1 and 2. The median duration was 4 days, and the supportive measures included tocilizumab, acetaminophen, steroids, and anakinra, but in few patients, and tocilizumab and acetaminophen is the most common supportive solved in almost all patients in 91, and 1 CRS followed by hemophagocytic lymphohistiocytosis. We will see also at us, I think that an important slide coming from the use of CAR-Ts, and it's the benefit in quality of life. This is something that you see in the clinic. After the first month, you see how the quality of life of the patients clearly improve. And this has been collected in the CAR-T2-1 study. And you can see how at 3 months after CAR-T, there is a clinical meaningful improvement in the quality of life, improving clearly the pain, fatigue, physical function, and global health status. And I think that you can see here in this slide how the fatigue and the pain significantly improved, and maybe, and from my personal point of view, in the longer follow-up, you can see how some patients receiving CAR-T cells have a quality of life, I would say, almost comparable to the normal population. Do you consider that this data cover the unmet medical need we have in multiple myeloma for patients already exposed to proteasome inhibitor IMiDs refractory to anti-CD38 monoclonal antibodies? This observational mammoth study, in which we know that in this situation, the overall response rate with subsequent lines of therapy was 31%, median PFS 3.4, median overall survival 9.3 months. I think that if we look only on the overall response rate, complete response rate, but even progression-free survival and overall survival, I would say that clearly CAR T cells targeting BCMA are covering the unmet medical need. In the near future, we are going to allocate these BCMA CAR T cells maybe in patients in a third line and beyond. And from my personal point of view, I think that the label should be relapsed and refractory myeloma patient exposed to at least 3 or 4 therapies, including proteasome inhibitors, IMiDs, and anti-CD38. Most of these patients are going to be refractory to the last line of therapy. And from my point of view, I think that it is not necessary all patients to receive bortezomib, carfilzomib, lenalidomide, pomalidomide, daratumumab, isatuximab to arrive to the CAR T cells. And once the patient has been already exposed and even refractory to PI, IMiDs, and anti-CD38 monoclonal antibody, I think that we can go to BCMA targeted therapy, and CAR T cell is one possibility. And definitely because we know that when patients are becoming refractory to bortezomib and at least thalidomide or lenalidomide, or even carfilzomib and pomalidomide, the median overall survival is of approximately 9 months. The same observation in the Mammoth study, including patients refractory to anti-CD38 monoclonal antibodies. So definitely it is not necessary to wait our patients to receive all PIs, all IMiDs, and all anti-CD38 monoclonal antibodies. The clinical development plan for BCMA CAR Ts is great, and we have some clinical trials in earlier lines of therapy and even in the upfront setting. And I am going to show you just the study design of the CARTITUDE 2 study, in which different cohorts of patients are CAR Ts to first line of therapy, patients transplant ineligible with ISS3, or even some patients already exposed to BCMA targeted therapy, or some patients when they don't achieve an optimal response after autologous stem cell transplantation. So this is excellent, and together with this phase 3 randomized study, the CARTITUDE-4 study in patients just after 1 to 3 prior line of therapy, in which the control arm is going to be PVD or darapomalidomide and dexamethasone. These 2 trials are ongoing and definitely will allocate CAR T cells earlier on. Outstanding questions for CAR T cell therapy in myeloma that I am not going to address because of time limitations. Leukapheresis product, very important. Optimal timing of CAR T cell therapy used in treatment, something I have just discussed with you. Predictors for CAR T cell response and toxicity. CAR T cell expansion and persistence, T-cell fitness, something relevant, as well as the pharmacodynamic, cytokine levels, as well as what is the role of soluble enough. Well, it's true that even in CAR T cells in other diseases like ALL or diffuse large B-cell lymphoma, maybe we are not observing yet the plateau phase reported in other diseases, but we are in the appropriate way in order to reach this plateau.
So do we have still a role for allo stem cell transplant?
Yeah, this is a good question. And at the end, allogenic stem cell transplantation in myeloma is one of the first concepts showing that immunotherapy works in multiple myeloma, the role of graft versus myeloma. And I think that there is a role, although more and more limited. And what is the situation? In our center, we offered in the past allogenic stem cell transplantation, for example, to patients early relapsing after the first line of therapy with high risk features. If the patient had a donor, we offered him or her allogeneic stem cell transplantation. Now, if we have a BCMA targeted therapy, CAR-T or bispecific monoclonal antibodies, we prefer to utilize this modality of cell therapy. And honestly, we are decreasing the number of allogenic stem cell transplantation because there is another problem. Allogenic stem cell transplantation is always an exclusion criteria for all clinical trials. So if I do an allogenic stem cell transplantation in early relapses, this is going to preclude the inclusion of the patient in subsequent clinical trials. So it works, but I think that it is going to be less and less used in favor of these cell therapies.
Thank you, Dr. Matthews. That's very clear. Thank you. So I think we are enough for the question. So thank you again, Dr. Matthews. I will move now for our third guest speaker, Dr. Saud Al-Haili. Dr. Saud is a consultant physician at King Faisal Specialist Hospital, Riyadh. Dr. Saud has special interest in multiple myeloma. So he will share with us today some of his cases, and we'll have opinion from our other guests about it. The floor for you, Dr. Saud. Thank you for joining us.
Thank you very much. I have two cases I would like to share, one for frontline and one for relapse setting. So the first case is a 51-year-old lady who referred from primary physician with anemia and elevated total protein for evaluation. So that's her basic labs, showed some anemia. Her total protein is high with normal albumin, so she was referred for evaluation. So she had serum protein electrophoresis and immunofixation, which showed an IgG lambda M protein with 34.5 gram, which is 3.4 gram per deciliter. Her IgG was elevated around 52, and her free light chain repeated twice was high. Lambda is high, and the kappa lambda ratio is below normal. She underwent a bone marrow evaluation, which showed hypercellular around 80%, and with lambda restrictive, and it was diagnosed of plasma cell myeloma. The FISH analysis, which we do at our center, showed normal cytogenetic, so she's a standard risk patient. So she was diagnosed as an IgG lambda multiple myeloma, standard risk. So after a long discussion, so we use sometimes VCD and VRD protocol. She want to continue her therapy in the United States, so we started with VRD protocol. However, after 4 cycles of reassessment, showed that patient did not achieve partial response. Her IgG is still elevated around 28. Her M protein is around 20 gram per liter. So a question, so what do you do next? So do you add daratumumab? Do you change to KRD? Change to KCD? You be more aggressive of VRD-based chemotherapy. So Dr. Matthias, what do you think? What would you do with this patient usually?
Because I was muted, yeah. I would like to ask you, well, from the theoretical point of view, if the patient did not achieve a partial response, I think that it would be appropriate to switch in order to put the patient in at least a partial response before going to autologous stem cell transplantation, because we know that with VRD, the overall response rate is around 90%, putting in context that almost all patients are able to achieve at least partial response. So from my point of view, what I did in a patient, a lady that I had in a similar situation, but with 11-14 translocation, not specifically standard risk, was to give 3 cycles of carfilzomib, dexamethasone plus daratumumab. Because, well, one possibility is just to add daratumumab. I think that the monoclonal antibody anti-CD38 has to be incorporated in this subsequent line of therapy. And you can combine with VRD change it to KRD, I think that is not enough because you are going just to switch from bortezomib to carfilzomib, and the dose will be 36 milligrams per square meter. So maybe you are not going to reach an optimal response. Carfilzomib, cyclophosphamide, and dexamethasone would be a possibility because you switch and you are going to prove chemosensitivity to cyclophosphamide. And VRD base, I think that is too much if you plan the patient will be candidate to autologous stem cell transplantation. So either daratumumab, KCD, or KD plus daratumumab.
Okay. So actually what we did is we gave her KCD, and after 2 cycles, she achieved partial response. And we were planning for stem cell collection and transplant. However, patient decided to go for Mayo Clinic for second opinion and bone marrow transplantation. She was evaluated there. She was on partial response, and then she undergo frontline with melphalan-based autologous stem cell transplantation. And now the second question is what to give her in a maintenance after the stem cell transplantation. So what do you think? What maintenance would you give her? You know, she's refractory to Velcade, she's refractory to Revlimid. Would you combine them? Would you give DARA-based maintenance? What do you think?
Well, honestly, I have a similar patient in this situation. As I previously said, my patient received KD DARA as well as a second induction before autologous stem cell transplantation. And after autologous stem cell transplantation, I had exactly the same question you are planning to me. And honestly, for me, the optimal situation in my patient would have been to continue with the DARA maintenance, but it was not allowed because it was off-label. And in fact, honestly, we don't have any data about the DARA maintenance. We are going to have some data coming from the Griffin study with good results, but well, it's off the label, at least in Europe and in Spain. So we can utilize basically Velcade, Revlimid, or Velcade plus Revlimid. What I decided to go is to utilize lenalidomide as maintenance. It's true that your patient did not achieve at least PR with bortezomib, lenalidomide, and dexamethasone. It's difficult to attribute the lack of response to either bortezomib or lenalidomide or dexamethasone. And at the end, I decided to start the lenalidomide, and the response was improved and even was maintained for approximately 2.5 years. So I would recommend you to go to lenalidomide.
So she was started on lenalidomide. However, after 8 months, she started progressing. So now she's on, we don't have, so DARA is not approved for our maintenance too. So she was Revlimid, started as a Revlimid maintenance. Then in 7 months, she progressed. So we give her DARA Pomdex as therapy. Currently, she's responding. She's on CR actually with DARA Pomdex. She's doing fine.
Okay.
So we'll go to the second case. So a 65-year-old male presented to local hospital with fatigability and severe back pain, and he was confused. He found to have acute kidney injury, and creatinine reached to 450 micromole per liter, and he had hypercalcemia with 4.5. So they started him on hemodialysis, and they gave him Zometa for, pomodronate for his hypercalcemia, and he was referred. So this is his baseline. So he was anemic. His total protein is elevated. His creatinine when he was referred was 307. IgG is elevated, and so basically he had an IgG lambda multiple myeloma. So we did a bone marrow which showed clearly he was hypercellular, and he was diagnosed with a multiple myeloma. So we started him on VCD because of his kidney injury, and he achieved kidney function improve, however, stabilized at 140 to 160. And after 4 cycles, also he went to the UK for stem cell transplantation. He had further 2 cycles, and he had undergone auto transplant on July 2019. Then he presented again, like around 3 months after transplantation for evaluation. He was in very good partial response. He was started on Velcade maintenance. That's patient preference. So he doesn't want a Revlimid maintenance. And however, after 9 months, he presented with pancytopenia. He was fatigued and feeling unwell, with platelet dropped to 26. So we held the Velcade when we assessed him. Creatinine was stable. However, his free lambda went to 14,600. He was distance was difficult to do every 1 or 2 month follow-up. So we are doing every 4 months because he's living 4 hours from our city. So his free light chain has jumped to 14,000. So we decided he's Revlimid naive. So we give him DRD protocol. However, it was difficult because with his creatinine, even with the lowest dose of 5 milligrams 3 times per week, he has fatigue, cytopenia. So we decided just to continue on DARA. However, and he has improvement, like went the free lambda from 14,000 to 900 on follow-up. However, recent lab showed further increase despite DARA. So he's just finished the every 2 weeks protocol. We're planning to move to the monthly daratumumab, but his fatigue and he started to have some anemia and thrombocytopenia. We repeated bone marrow showed sheet of plasma cell, and the free light chain went up from 900 to 3,600. So now the question is, should we just add pomalidomide to his DARA? Should we put him back on VCD? Should we change to Velcade, Bomcidix, or KCD, DARA, Cyclodix? What do you think for him?
Well, I think that this patient was treated basically the first line with a proteasome inhibitor-based combination, including autologous stem cell transplantation. The second line of therapy was daratumumab in combination with lenalidomide and dexamethasone, but lenalidomide was not well tolerated because of the renal function, and now, well, the patient is progressing on daratumumab. So one possibility is to add pomalidomide, but personally, I don't know if you, how many cycles of lenalidomide did the patient receive? Few cycles.
Yes, few cycles, around 3 to 4 cycles. So we went from, we started with 10, to 5.
So there is a role to add pomalidomide, because in fact, pomalidomide does not require the dose adjustment by renal function. So one possibility would be to continue with the daratumumab and to add pomalidomide in order to see if you see synergistic effect and the patient respond. If not, other possibility would be to go to carfilzomib, cyclophosphamide, and dexamethasone, or pomalidomide, cyclophosphamide, and dexamethasone. I think that this would be maybe my options.
Maybe he's because he's far away. Maybe Bomcidix.
Yes, sure. You are right, because it's true that you said that the patient was living 4 hours from your hospital.
Yes. I'm gonna see him next week, so we'll discuss with him this option. I think this is I'll conclude my 2 cases.
Thank you. Thank you very much, Dr. Saud, and thank you, Dr. Matthews. Thank you very much. So we have time for a couple of questions. Dr. Saud, if you have any questions about the presentation for.
So I know if you're giving the anti-BCMA, you might lose the CAR T cell effect. So if you have the 2 options, the belantamab and the CAR T cell, so which one you go usually for your patient?
Well, definitely between belantamab and CAR T cells, I think that, both approaches are targeting BCMA, but if you compare the overall response rate and the complete response rate, definitely is much more better for CAR T cells than belantamab mafodotin. It's true that the durability of the response is comparable. With belamaf, 30% of the patient responded, and the median duration of response was of approximately 11 months, comparable to that reported with CAR Ts. The problem is that much more patients responded with CAR T. And it's true that, in my clinic, I have, several patients treated with BCMA CAR T cells, and, almost all patients respond. And it's true, I showed you the slide about quality of life, but this is something that you see in the real life, because as patients arrive at the hospital before the lymphodepletion with a very aggressive disease, because sometimes it is challenging to wait the bridging therapy between, while the T cells are becoming manufactured, while the patients arrive sometimes in poor conditions. And after the lymphodepletion and after the CAR T cell infusion and after the toxicity in the short follow-up, well, patients recover immediately and the quality of life is great. And it's true, I have some patients with more than 1 year of follow-up. They don't have to come to the hospital very frequently. They are not receiving any therapy. And definitely the quality of life, I would say that is, well, quite similar to that observed in the general population. So it's great.
Okay, thank you.
Okay, thank you very much. Thank you. So I have no further question from the audience. So thank you very much to our speaker and for our audience attendance, and would also like to thank our sponsor. I would like just to take the chance to show you this invitation for our next event.
Thank you very much.
Thank you, Dr. Matthews. Thank you very much for your time. And thank you for
have a nice evening.
Thank you very much. Thank you. This is for our audience. So I would like to invite you for our next event on next Friday. We have our 7th Saudi reception and perception of ASH 2020. This will be a nice webinar, about 3 hours. You are all welcome. Again, I would like to thank our guest speaker and our all audience and our sponsored. And thank you for Saudi Society for Blood Disorder. And thank you all. I will conclude our webinar for tonight. Thank you very much.